Good evening. Welcome everyone. Thank you for joining us today's webinar. Today's webinar is very special, and my name is Shamim Hassan, and I am the editor and publisher of physionews24.com. Today, we are presenting a basic prescription format for the physiotherapist, presented by Dr. Shantonu Mallik. If you have any question during the presentation, please text write in the comment box. And now we are connecting with Dr. Shantanu Mallik. Hello.
Thank you, Dr. Shamim. And hello, good evening, and most welcome. Because that is previous webinar, I am the host. So today I will talk like a speaker for today, but I think I am also the part of Physio News 24. And thank you, Dr. Shamim, for inviting me or give me the scope to talk on some that is the very new, not new, it's a old topics, but we will just recapitulate or we'll try to make some breeze from our basic to present. And these topics will be, I think, similar. But before that, I will like to introduce myself. I am Dr. Shantonu Mallik, and I am a consultant physiotherapist in a government sector in Bangladesh, and especially that is in Social Welfare Ministry of Bangladesh. And I'm working in the disability section, and that is National Disability Foundation for Disabled Person, and I'm the consultant there. So today I will discuss, and before that I will like to, I, I beg pardon for the delay because already it's 20 minutes late. So maybe that the reason is behind there is some technical issue. So today I will try to discuss some very basic, and directly I want to go to the next slide. That is every we are used to know that is the history of physiotherapy, and it is very common in Wikipedia. You can find this type of lecture, but I will just try to show some of our ancient picture that is related to our physiotherapy. And first of all, I would like to inform something like why we need actually prescription for physio. Because you know that we have completed 5 years graduation, but in this subcontinent or any other places, there is no concrete rules and regulation for prescribing because we are the physio and we have different professional than others medical professionals. So for this reason, I think we should develop at least basic prescription method that is should be unique for physiotherapists. That's why today lecture will be like which techniques we are going to use regularly and which techniques will come first and which techniques will come last. Just we are discussing. It's sorry to say that it is a one-way communication. But if you any queries, then you can just ask me on comments and box, and I will try to give answer. There is some flashbacks that is in during this ancient time. This type of picture you can see that is some physiotherapy is like a, they are doing regular basis. And then next, if you want to see some Egyptian or some others area of the world, they are used to give physiotherapy is like a massage cutter. But if you want to see something that is in Chinese, they are used to give this type of approaches in physiotherapy. And these the modern approaches. They are you can see some manual traction. They are given by with manual force. And these all pictures are available in the Wikipedia, so bit about that. So if we see that's early history of physiotherapy, and if we see that's a father of medicine is Hippocrates, and Hippocrates we can call that is 460 BC. Hippocrates is the father of manual manipulation for pain relief. And another person is very, we have to remind his name, that is Claudius Galen. And he's the person, he especially quoted all invention of Hippocrates. And so it is very important to remind his name, because without his quotation, we can get a lot of theories from the past. And also, I would like to just give some idea that is father of physiotherapy. Like, uh, it's very common, like Per Henrik Ling is the father of physiotherapy, because the physiotherapy name came by his creation. I think he's the Swedish person, and Swedish person, and especially he's working in the gymnast, and he has given the name of physiotherapy. That's why we are now physiotherapists. And another is a mother of physiotherapy. If we like to remind the mother of physiotherapy, and he is Mary McMillan, and he is the founder of APTA, American Physiotherapy Association. And next, we can remind someone that is Shirley Sherman. She is the first board of director of this APTA. And after that, we'll maybe some network issues there. So sometimes we are very slow on slide sharing. So sorry for that. And then I would like to remind some the greatest women in our field, is Florence Kendall. And muscle testing is our basic assessment tools in this field of physiotherapy. So she has invented this muscle testing approaches, and also orthopedic. So we have to remind her. Just see the face of the pioneers of our physiotherapy. And this is the, this we have got a lot of techniques from our sister's husband. So I is called in Bangla is called Dulafai techniques. Like we have got the brother who is the husband of our sister. So Carl and Bartha Howard. So Carl, he was the neurophysiologist, and also that is he was working in for the child neurology, and his partner was Partha Bogart, and during the Second World War, they are working together, and they have invented the techniques, Bogart approaches. And this is very best approaches for neurology and the physiology. So thanks Partha Bogart for give us a chance to practice Bogart. And another famous lady in physiotherapy, by the help of her, we have got the technique, that is Sirex approach. Dr. James Sirex is the father of orthopedic medicine, and we have got the techniques from him due to Patricia. Patricia. Patricia, the nickname is Basti, and she uh, she was the wife of Dr. James Sears. That's why you have got the technique. So thanks to Patricia for for her. I think it's a great approach, and we are a lot of eager to learn this serious approach. Another person that is in our field is a famous person, and Friedrich Kaltenbrock. And he's, he was a directly student of Sirex, Dr. James Sirex, has learned a lot of techniques from him, especially His approach is very known to in Canada, that is OMT approaches, OMT courses. But after completing his CREX approaches from the CREX, he's going to give lecture, used to give lecture on all medical person who came to him for his orthopedic manual techniques. And Carlton Bone, he has given some basic idea on physiotherapy, that is the joint range. And we have divided the range in mainly three parts, that is inner, medial, and outer range. And also he has given some explanation of that Fitts law. So concavity groups, he has clearly defined to us. So he's our one of the pioneer in the physiotherapy field. So just try to remind, because he has died in 2010. So we have lost one of our greatest. Uh, okay. So another pioneer in our field is Jeffrey D. Maitland, and he is he was an Australian, and Maitland approach is very common in our physiotherapy practice, and I think this approach is very famous, not only for physios, also in other medical practitioners. But he has given tremendous approaches like creating on mobilization, and that is we are used to give the mobilization on the vertebral column or in the facet joint. So there is a grade, five grades, and that's five grades are mainly four grades are including in Maitland, and the fifth grade is including in serious concept. So he also got the knowledge, this type of manipulation knowledge from James Sedax, sir. So a lot of techniques we are using in mobilization and manipulation. That's not directly invention of physio, but they are making some different way. They have presented among us in different way. But I think it's derived from mainly on that orthopedic medicine. And also this is the still he is alive, and our another great teacher is still in New Zealand, and it's a very nice, good brand name, and still alive. So we are very lucky that we have this famous person still in the world. So it's a very we are very lucky, and we can learn a lot of still we can learn Mulligan approaches by this live classes. So it's a very energetic person, and very is a very funny person to learn. And another person in our field is Robin McKinsey, and we have lost him on 2013. And he has invented some approaches that is called McKinsey approaches. So this is very common in our physiotherapy field, and that's approaches. These approaches are little bit different than each other. It's not very common, but sometimes you can find, okay, this is hands on, this is hands off. But I think it's a very few basic difference. Which only is your hand position will be there, and which approaches your hand position is another part. So this is just basic difference, but the anatomical basis or biomechanical basis or your treatment approaches all are little bit on basic same. So I will discuss it later. And another person in our physiotherapy field is Thomas Andrews Brown. So he's the we are very sorry that he was an Australian, and his approach was famous among the world after his death. During his lifetime, he was uh, he was tried to make his approaches uh, common, make it easily accepted by this Australian Physiotherapy Association or any other places. But during during his lifetime, it wasn't possible for him. But after his death, a lot of research came and now showed that this technique was better. And it's not a massage, it's different type of approaches. So I will discuss a little bit later. And another person, he is a doctor and physiologist, and John N.C. McNeil, and he has given the name of dysfunction. Dysfunction word is came from that is John N.C. Medal, John N.C. Medal, and he's the give this word, and also he's described some special topics on that is related to our mobilization and mobilization. I think screen share is not share properly. Okay. Then another thing is another person skin is properly shared or only start down. I'm not sure. Okay. So now I will like to please wait for some time because the screen is not sharing. Okay, some network issues there. Okay, thank you. Now I will like to introduce that is Jean Pierre Barrel is the physiotherapist. He is the famous physiotherapist in France and French osteopath and physical therapist. And he has invented one of the greatest approaches in physiotherapy field, that is visceral manipulation. So we know that we can manipulate the soft tissue, we can manipulate the bones and joints and hard tissue. But nowadays, after his invention, we can know that we can move the viscera, the vital organ like liver, we can move some colon, we can move some any other part in the abdomen. So when you chronic patient will come and they have presented some liver pain, and you are not sure that which from where is refer. So then you can easily approach some visceral manipulation, and that will magically, tremendously cure that refer pain. So it's a very nice approach. I will discuss later. Stanley Paris, he's one of the famous physios, and there's a lot of in this subcontinent, like Pakistan, India, and Bangladesh. So in Bangladesh, we don't have a scope for that is DPT, Doctor of Physiotherapy, and also same problem is on that is in our this neighboring country India. But in Pakistan, they are very common DPT in the field of physiotherapy. So they have to come to know that is maybe they are used to know that Stanley Paris is the first. He has done for the creation of the Doctor of Physical Therapy, and his all work his all works were for that making that this DPTTP in the world. So he's from New Zealand, and also he has given the another approaches for diagnosis, that is joint status. So from 0 to 5 grading we have used in case of joint status, and this is given by this famous person Stanley Paris. And now I like to introduce some of my mentors in this physiotherapy field, and I have learned my basic and everything, and I have always inspired to see my this. Only 8 people are there, but I think I have a lot of teachers. I have got blessings from them, but I'd like to introduce my I want to show some of my mentors' teacher. So Dr. Shantonu Mallik is my basic teacher, and Professor Dr.Shantonu Mallik, Deepak Kumar Kepi sir, Professor Subhash Khatri, Professor Shobna Agarwal ma'am, Arunmoji Ranganathan sir, Arpit Singh sir, and also the Linji Madvis. And from everyone, I have got 8 different type of topics from my basic to still now, and I am always following. So today lecture is already I have mentioned that is we want to today we want to just try to mention some basics. Not is a new creation. It's just basic on your what you are practicing day by day. Look, what you have learned in last 5 years is not important. But when during your practice, you are giving a written document to your patient is very important because nobody will care about what you have learned last 5 years during your undergrads. But when you are giving a written signed documents on your patient, then will be the matter because it should be unique and it should be some representation of your all skills. So without giving these written documents, we are now deprived in profession, in medical profession. Like another profession came to give prescription, like physiotherapist or physical medicine. They are now they are now saying that is we are the person for only prescribe and physiotherapist will follow that. No, that's not possible. We are the unique profession in the world, and we have the unique right, and we have the 100% right. That is, we only prescribe physiotherapy, not any. We are copying other professional. We have to copy our profession, and that prescription should be unique, and it can be varied according to your patient, according to your conditions. And first of all, you have to know that we are not treating condition. We are the physio. We are not treating any condition. Like we are not treating osteoarthritis. We are treating the sign and symptom of any condition which are on favor of us. That is, we can manage the pain, we can increase the muscle power. This is all are symptomatic. So you have to keep in mind that we are the physio, we are not treating any disease. We are treating the sign and symptoms. So that's why we have to know that which sign and symptom is in our range. That's why we can treat, or we can manage, or we can give better lifestyle than the before patient has continued. So that's the reason we have to think that is prescription should be also unique, and that should be like a physio prescription. Like if you can see this format, there is a in the two side. The first side is like here you can see that's in the first side. Here the right hand side of your prescription, that is demographic data. On the top of there is name, age, sex, and date or something. And then the first question is subjective objective analysis and plan. This is called, we are called SOAP, but that is different. That is different because on the assessment page, you have to keep that page on your own record. Or if patient demand, then you can give some summary of that your assessment. But prescription, this single page or double page, whichever you are planning, but single page, most of the time, this single payment you have to give the patient on hand. So this page will, they can show all over the world. So that should be unique, and some in some point that should be your presentation. So that's why, like first step is chip complaint. So patient will come and they will present a open-ended question. Don't ask any question, close-ended question, and that will become after during your history taking and your on examination. But when the patient talk, then that will be open discussion. And whatever thing patient like, please give them time and pay attention and make some note during patient explanation, but please give them time to explain themselves. So then the point is come history of present couples, how long that problem they are threatening, or they are bearing. So because by asking this question, you can measure that is whether that problem is acute or subacute or chronic. This is very vital. So very important. And also, this chronic pain management is now very different than the acute or subacute management, because sometimes it's going to central nervous system and central sensitivity, then the management will be different. And now a new branch is coming, like that is cognitive behavioral therapy. So new problems and new approach also there. So that will be more critical. But for past medical history, nowadays we are checking a lot of common diseases among the patient, like diabetes and thyroid problems and their cholesterol or any hypertension and some uric acid. This is some common problem, or hemoglobin particles, so, or any that come in the investigation parts of some common diseases which can increase their sign and symptom, which you are going to treat. So previous medical history and previous any type of diseases, you have to be monitored and you have to make a note about that. And the drug history also important, because some drug can create problem during your exercise. So some drugs are strictly prohibited, like okay, or some drugs can create. You have to take take time, because after half an hour or after 1 hour you can go for exercise. So please ask your patient and make a note that is which the drug will hamper on your exercise or not. And another important topic is on examination. So most of the time we don't have time to prescribe or take any examination. That is, there's we are the masters in physiotherapy, and we have the skill, that is clinical test is the main important things for our as a physios, because we have a lot of personal invention, like one of our famous physios, they have created a lot of specific tests by their research. That test is unique for physios, but we are commonly based on the medical researches, and some tests are already embedded in the world. So that tests are very unique, and some tests are more reliable, and some tests have more specificity, and some tests are more uh, that test nowadays is called evidence-based practice. So some tests are more specific to find out some diseases. Like if I can give you example, like you have a patient with a neck pain and also refer. So how can you be sure about that? So you can go for Sparling test. So Sparling test can give you some 100% that is confirmatory test for nerve root compression. Or first of all, you can ask the patient to put your hand over the head. So if symptoms relief, then you can first assume that okay, it is due to come that pain from neck area. But if you are applying that Sparling test, axial compression and same side bending and rotation same side, and then give axial compression, then you will be more 100% sure that is the cause of root compression. So this type of technique are a lot of they are, and but you have to put that note on your prescription, which test you are giving on that patient and why you are confirmed. Because the diagnosis, we are not going to give any confirmed diagnosis, because I will discuss later. But here on examination, there will be it may be one test, specific test. You are quite more sure that is this condition is this, or you can give some another one or two tests, clinical tests that will can more support on your prediction. And another is we are in our subcontinents, we are more dependent on clinical test. Sorry, is investigation, that is a pathological test or any diagnostical test. Look, we have learned 5 years graduation, so uh, investigation which are given is some layman or some merchant people. They have the own business in the pathological sector. They have the diagnostic center. So why we are depend on them? So better at least more than 50% you have to be confirm on your clinical test, and after that, if you want to confirm your diagnosis or your prediction, then you can go for some pathological test, and that will be more common, and your prediction will be more strong than your clinical test. So you can go for X-ray, MRI, or any blood serological test, anything. You can go for your support your prediction or support your probable diagnosis. And then the come is for diagnosis. And here you have to be sure. You have to be more. I think you have to be more cautious about your diagnosis, because diagnosis should not be confirmed. Here I will show you later. That is in the end of that lecture. I will show that is diagnosis should be, that should be like a what is it? Provisional diagnosis. You have to maintain on bracket, that is provisional diagnosis. It's like a first assumption of your clinical. Like first assumption means you have to, which plan you are made for your patient is a first assumption. Okay, you are just temporary diagnosed, that is this condition is coming. So you can go for you can go for on prediction, and same maybe there will be differential diagnosis on behind. So first you set a goal, that is set a plan, that is this condition may be happen. So you put it there, but in bracket you have to mention provisional diagnosis. Then what happened? You are then secured from law, because no medical ethics violation will be there, because you are not only the right person to confirm that diagnosis. If you are continuing the treatment plan and patient has got cure, then when patient came for follow-up for the last time, then we'll cut their provisional diagnosis. Then you can mention that he was right. He was right. That's why you cut that provisional phase. But before that, when you are continuing your treatment, don't do any confirmation diagnosis. You have to put your provisional diagnosis, then you are out of danger of any kind of medical ethics violation. So nobody will go sue against you if you mention that provisional diagnosis. And this is very, I think it's my point of view. It's a very safe practice, and some big diagnostic center, big hospital, they are practicing this. So they are safe on the law of medical ethics violation. So you can continue that. And then advice. The last point will be advice, because you can advise some lifestyle modification or something. But here on the left side, like RX, through the God, or by the name of God, we can start. This RX, they are the question mark. What you can put. So by step, I can show you, because it's a like a where here now you can see that is the direction of treatment. Direction of treatment means which direction we are going to treat. We have the physiotherapy, we not like a medicine. We put the medicine inside the mouth, and it will go stomach, and then intestine, it will suck, and then it will mix on the blood. No. We are the physiotherapy, also our technique we are applying, that is on skin. From the skin, and then we think that is we will going to treat that at last stage is bones. So you can easily predict that our outer layer is skin, and then fat layer, and then skin and superficial muscle, there is a fascia. So superficial muscle, before that, that is superficial fascia, and then deep muscle, then deep, before that is deep fascia, and then after deep muscle there is a periosteal layer, periosteum layer, and then the bones come. So if you see that this the sequence like here, so we are treating from skin, all electrode device we are applying on the patient, that is from the skin, and the non, especially we are using the non-invasive approaches, but we can now applying dry needle or acupuncture. This is invasive approaches. So that also the last barrier is anatomical barrier or that bones. So we can cross that. So this fascia, before that we know that's all bread and butter for physios are muscle, but nowadays it just improved. Like we don't only muscle is not our bread and butter. Fascia is also our bread and butter now, because fascia is a large connected organ that is, it is placed all over the body and all are connected to each other. So it's a very large system now. So in muscle we can get the group of muscle and group of action or unique action of the muscle, but all fascias are linked together and they are separate the segment of the muscle, or they are segment of the that is the viscera or everything, they are separated by that. They are covered by fascia and also segmentally separated by fascia, but all fascias are linked together. So it's very important to treat the fascia, because these fascial space are allowing that nerve system and the vascular system. So this is very important. So if we not release that fascia, then some research says if the fascia's compression on muscle is 40% to 60%, then the muscle blood circulation will be zero. So it's very important. Fascia is this that type of connective tissue. If it is injured, then it will constrict. So it will constrict inside of that fascia. Every soft tissue they will constrict. So this is the new invention and the first approach in our physiotherapy treatment, that is myofascial release or any other approaches. So I will discuss, not show because it's a large department. So I will just today I will discuss everything, so you can understand that which training you need to get or which treatment approach we should be applied. Okay, so this is gross treatment phase for physios. Like uh, for we are treating the patient in the three stages, like acute, then subacute or chronic. So in the subcontinent, we have got the patient most of the time in the chronic stages, because they have already completed a lot of medical professional, and then finally they came when they can't do anything. So we are the last person to face. So most of the time we are getting the patient in chronic stages, but in acute stages, we most of the time we get on sports, and sports is the only sector where we can heal that is called healing. Healing can be possible only the sector of sports, not in the other sector, and regeneration only can possible in the sports, because sports is a different side, and I think their physio should be go that field, because they are not used to go in the sports side, but it's the only place where the regeneration can be possible. But other sector, there is the fibrous adhesion or degenerative changes. These three segment on the soft tissue mechanism. So if I can discuss that is just shortly I can discuss the our bread and butter to treat the soft tissue. So soft tissue are mainly that is injured by two ways, that is micro and macro. And after that micro and macro, there is a change in the cell matrix. So if you are continuing that injury in the training pattern, training manner like a sports person, they are always training and then wear and tear and there, and then healing is possible. So after the training effect, after the continuous training, then regeneration can be possible in the sport. But when the soft tissue structure have a more vascularized side, and that damage in the vascular spot, vascular segment or vascular structure, then the classical inflammatory sign will be there, and the final fate will come a fibrous adhesion. But those structure like cartilage, if there is any damage, then there is a less circulation, or there is no circulation. So that cartilage cell will atrophy, cell atrophy will be there, and then the fate will be the degenerative change and chronic disease. But what happened in the field of medical practice, we are fighting on that side. There is the final stage should be degenerative change and chronic degenerative. We can't stop that, but we are not treating our patient in that sports side. There is a regeneration is possible, and also we can change muscle or soft tissue. Those who are vascularized, there is a uh, we can limit our inflammation, and then we can prevent the part to going to be a chronic degenerative change rather than the fibrous adhesion or fibrous tissue formation. But that those structure are vascularized, there the fate will be confirmed, that is fibrous adhesion will be there. No regeneration always happen. In some structure there is a regeneration happen, but most of the time in muscle or any other soft tissue there is a fibrous adhesion is the last stage. But if you're not treating properly, then that will be chronic degeneration. But you have to remember that in case of that is cartilage, the vertebral discs, that result will be finally that's degenerative case. So that's the what I have mentioned in before. That is the stage of treatment is the cross term is not a specific. It's depend on the condition. Like acute phase, we are looking that is a 1 week is the acute, and then the second week to third week it's subacute, and after the 21 days or third week we can predict that is chronic. But it's not a concrete message. It can be flexible. Like you have ankle sprain and you are continuing weight bearing on that ankle sprain, and it's up to 1 month, that will be acute. So it depends on the condition. It's not a concrete or fixed approaches, but I am just mentioning here. Okay, now for management of acute injury is a nice approaches for physios, and we are in case of sports we are treating this type of approaches, and in some years before we are used to know that's rice approaches there. Nowadays we are very common that is price approaches, and recent as but is foolish. So I can go for the acute approaches. We are using mainly the eyes. So if we go for the rise, that is raised eyes compression and elevation. For price is now coming the protection, because that's injured part of that body should be protected properly with cast or any immobilized structure. And then is raised eyes compression and elevation, because compression will be the extra fluid will come and inflammatory sign will increase. So here, I think the compression is the more suitable, and elevation above the heart level is very common. So it's a very common approaches we are using, and also we are guide the patient in home care. So, but the push is very important. For rise, I can show this slide. Rise price is also very common among the physios, but for push is very important, because nowadays push come, because protection is as usual same as before, but optimal loading is important. Why it is important? Like those structure has no contractile structure like actin myosin, not like muscle. Tendon is not like muscle, and also ligament is not like muscle. They don't have the contractile structure protein there. So when that injured or fiber or tear among the tendon or ligament, then if you are put that part on resting condition for a long time, then there is a might chance of increase the fibrous adhesion. So that part will not regain the elasticity of that part. So that's why you have to be use some little bit loading that should be optimal. It's among that threshold level of the recurrent injury. So this is the expertise of physio. So how we can load that part of that patient. So you have to be keep mind, and your all experience should be there to give that optimal loading. This is very important nowadays. So those physios are expert and they have experience. They can use these Polish approaches. So now we can go subacute and approaches, because we know that especially we are common to take this type of patient in that field. But there you have some lot of approaches in this field, like we are doing in case of chronic approaches, we are used to give this type of approaches, and we have this much of approaches in this treatment field. In case, especially in the musculoskeletal system, I will today discuss. So you can modify your prescription in any other field, like neuro. You have to modify something in pediatric. You have to modify something, or you can add some new treatment techniques. But this I will discuss because commonly we are practicing in musculoskeletal system. So musculoskeletal system, this type of approaches you can use on your prescription. So you can use your abbreviation or heading of that your lecture. So that will be a unique, because nobody will copy you. Other medical professionals, those who are competitor on this field, they will not copy you. So first approach is your electrotherapy, and then soft tissue techniques. Then you can correct your posture, and hard tissue techniques, bones, and then you can go for chronic approaches for visceral manipulation. You can go for rehabilitation approaches. You can go for nowadays we new technique is facial reflex therapy. It's a very nice approaches. Without medicine, you can give the home advice, and the patient can get more soothing effect after applying this. It's instant release. So before completing your physiotherapy session, you can just give the facial reflex therapy, and all musculoskeletal pain will be subsided very fastly. And so patient can practice every day on his home setup in front of the mirror. So it's a very nice approach. I will just show the video. So associated approaches, like you are advising some orthotics and prosthetic devices, so and counseling and area. So this sequence you can follow on your prescription. So I will go the every approaches and every discussion. Okay, electrotherapy. On electrotherapy, you are using a lot of electrical modalities, like eyes, and then that is eyes and electrical modality systems. There is a lot of machineries there for applying this whole, and then IRR, infrared radiation, UST, IoT, and then you can use traction and shortwave, FWD and laser and electrical stimulation therapy and Waxwork and biofeedback and etc. Lot of electrical modalities. I think it's a placebo, and few equipments can improve your patient condition, but it's not always. So I think we have to, some technical issues there. So sorry for the disturb. I have to go for. Okay, give me a second. I have to look for Shamim. Uh, screen share. The screen shareটা হচ্ছে না, তাই বলছি। Okay, so I have to share my screen again. Okay, some technical problem. So give me a time. Give me a few minutes. Okay, thank you, Dr. Shamim, for your help. So now electrotherapy, after that we'll directly go to the soft tissue approaches, and we have so many soft tissue approaches in our hand. We are commonly using, that is DTF, that is called deep transverse friction massage. Then soft tissue manipulation, or it's commonly known as a massage technique. Then we can use dry needle or acupuncture. It's also soft tissue approaches. Then we can use myofascial release approaches. Then we can use trigger point release, because you know this, after the injury of this muscle filaments, then the knot will be there. So that knot will be, how can we differentiate, that is trigger point. When you put that on that nodule, you put the pressure on there, will go spread along the muscle fiber, along the muscle layer. So if the pain is on localized point and tenderness, that is called tenderness, if the pain not spread. But if the pain, when you put the hand or put pressure on the nodule, and that pain spread along the muscle fiber direction, or and the muscle length, that is the trigger point. The positional release is one of the greatest approaches, and is also invented by physios. Sorry, one of the osteopath. So I will show his name. So this is another nice approaches for soft tissue release. Bowen Techniques is also made by Bowen, and he is also physios. And tapping is Kenjo Kase. He is a doctor and is from China. And cupping also is a ancient approach, and this is also for this is soft tissue approaches you can use. So this type of approaches you can use on the first approach in your treatment, that is soft tissue approaches. So DTF have, we know that there is some discussion about DTF, but you can find in more DTF figure on the CX concept. So CX concept, you can use the uh, specific use of application, or some different type of application of these techniques on the CX approaches. So it's a very nice approaches, and you can apply on field, in the sports, or any on your clinical setting. This can give you the nice result and instant result. Then you can go for manipulation, that is soft tissue manipulation or massage, and there is a lot of massage techniques, and that's massage is a big department for us physios. Nowadays is separated and more business approaches here. So by the massage is another massage professional are available, but we are used to do massage approaches in sports for regeneration or recovery after vital game. So trigger point therapy you can use Swedish massage and deep tissue massage, and a lot of massage are there. And this is a very nice technique. And for craniosacral therapy, there is also one kind of massage approaches, and prenatal massage and geriatric massage. And massage also very one of the greatest approaches. And you have to all of you know that we are coming from Massachusetts, and Flores Nightingale, that's one of the founder of nursing, and also some Massachusetts group. They have created this Nobel profession physiotherapy. So we are used to do that. And then we can go directly on dry needle. So I can show you sometimes. You can see some videos of dry needle here. So I'm using this. Maybe that's okay. So dry needle you can see the video, but sound is what is important. So you can just see how this dry needle is going on. So it's I think it's a long time I've taken. It's more than 30 minutes. So even patient mind is not for more than 30 minutes attention. So now you can see some videos, but maybe the network issue is there. That's why it's not clearly coming. So sorry for that. So trying another approaches. Wait it. So you can find a lot of videos and practice tools on Google, so you can Google it and get a lot of try little approaches. Then I will go to myofascial release. So give me time. Now I'm sure I need to help from Dr. Shamin because he is not sharing. So now our approach will come. The next approach is on the myofascial release. So myofascial release, we can use some little stress on that muscle and fascia. So there we can stress for 1 minute, or is depend on the structure. So by this stress, just a few, is not a large amount of stress on the muscle. So different direction you can apply that stress, and then you can get the result of release on that myofascial structure. So another topic. Okay, so next approach will be the trigger point release. So we have some, already I have discussed about the trigger point. So by the put the hand on the trigger area, and then you will just you can give some stress, or you can give some stretching on that part, or you can use your Bowen techniques, or you can use some dry needle or cup to release that trigger point, or you can use some muscle trigger point release approaches, specific approaches, which can be possible for your trigger point release. Yeah, talk with give me time. Okay. So then the next approach will come for, okay, I have to go through, but I can share my slide to you. Please give me time. Okay. So before this, I can share my slide. Now the treatment. Okay, I need little time to share my slide. So give me time. Okay, good share. Now the technique will come for the strain, counter strain, and that is another name is positional release therapy. And that's positional release therapy is uh, made by that is first made by Dr. Lawrence Jones in 1964. And he was an osteopath, and this is this technique is mainly uh, that resolves the pain and tissue dysfunction. So it's a very nice approach for uh, first techniques in physiotherapy field, and so you can release that muscle contraction or muscle tightness by these approaches. Then I can share my slide. That's why I can show you the video right now. But I will maybe soon Dr. Sharma will connect and help me to solve that problem now. So I think now another approach is tapping. So tapping is very common among physiotherapy field, especially in the because in the sports section and also in our clinical practice. So we are using the tapping techniques for sometimes is a corrective approach, for sometimes is a protective approach, and sometimes is supportive approach. So by these three type of approaches, we are using this that is soft tissue approaches, which are on from the surface oriented. We are treating. So like for supportive approach, when after the injury in the ankle or any ligament injury, then we have to roll the tape in strictly tight, and then we make the part is for resting condition. And then sometimes is corrective approach, some dysfunction or joint position, we have to correct and fix it there, and then with the functional movement will be there without pain or without any limitation. And some supportive approach means support and corrective, and then functional. Sometimes we are using this tape as a facilitation of the function. So that will also increase the function. Then we have a Bowen technique. So Bowen already I have discussed is like a manual soft tissue mobilization approaches, and that approaches also this the approach can guide your soft tissue and also is help to relieve there some uh, adhesion formation and also increase the circulation and also sometimes is improve the is remove the pain. So it's a very nice approach, and you can find more approaches and also courses on bound approaches. Another approaches for after when you are applying this type of soft tissue approaches, then layer by layer, like superficial layer and then deep layer. But in between that, I already mentioned that is in fascia, there is nerve supply is there. So if nerve is stuck on this between this fascia, so that information will not always pass easily on your brain. So then the pain sensation will be there. So you have to what you have to do, you have to move your nervous system. That is nowadays we have two ways we are moving the nervous system. One is Butler's approach and another is Shacklock's approach. So two ways we are moving the nerve, and in the two way, that is we are just moving the nerve in the slider approach. The both end will be moved in one direction, and then we have to approach the both end will be stressed. That is tensioner approach. So this both way we can move the nerve. So it's called neurodynamics. So you can learn a lot of these techniques on by different type of courses. So another approach is muscular approach. Now soft tissue is gone. Then our bread and butter is muscle. So there is a superficial layer and the superficial muscle and deep muscle. But for superficial muscle or deep muscle, what we are mainly using the approaches is muscle energy techniques. And one of my friends already on our platform, he has given on a beautiful lecture from Pakistan, Dr. So it's a very nice approach, and muscle energy is a like a whole relax approaches, but it is opposite to whole relax. Or sometimes we can mix it like a PNF stretching or something like that. But a whole relax muscle energy technique, and we have stretching for the muscle because for muscle we have to in first soft tissue approach we always try to those muscle are tight to try to lengthen. So for the beginning of the any type of chronic patient come for with chronic approaches, so we are commonly thought that the muscle has get shortened. That's why we have to make it make it lengthen. So we are using this type of approaches for muscle energy technique is the best one. So we can hold for 7 to 9 seconds with 30% or 100% energy, or it depends on the condition, which muscle and soft tissue and the tissue at fault. So you can choose your how many pressure you will apply, it's 30% or 100%, and also how long you will. That is 7 to 9. So this can patient will contract, and then when you say relax, and then you can increase the length. So another approach is I have the video, but sorry to say I can connect now. So stretching by stretching, in case of stretching, we can do three kind of stretching. That is static. So we hold that muscle forever and in static manner, and then we can do dynamic with the rhythmic way. We can do the dynamic way stretching. But nowadays we are using the conform stretching. It is the combination of static and dynamic. So this conform stretching we are mostly used on the field of sport. So this is very nice approaches. Then we can go for postural correction. So postural correction is like is in we are we have the patient mostly 70% are mechanical. So mechanical causes is created most of the bad posture, bad habit, and the environment and the lifestyle. So before going to hard tissue approach, we have to make a bridge by correcting the posture. So muscle is the only part of the body that move the hard tissue. So hard tissue make a structure, but this structure moves by soft tissue. So before going to the another structure like soft tissue to hard tissue, so we have to make a postural correction. So we can correct the posture by advising the patient or some other techniques, or like neurological approaches, we are correct the stroke patient by Bowen approach. So you can apply Bowen approach sometimes on the MSK system also. So it will give you some nice results. So it's depend on you which postural correction, like coaching, you have to correct or size the patient, or some touch your wall, and then you can give some abdominal or thorax exercise which can correct. So by seeking position, you can correct the posture. So by correcting the posture, soft tissue can make sense that is they are now relaxed. So then you can go for hard tissue approaches. So for hard tissue approaches, we have give me a time. So I want to contact with Shami. If he has this, Okay, sorry for that, and I think I have to go to complete that sharing screen. Sorry for the technical issue, and thank you, Dr. Shamit. And now maybe someone is already yet, but sorry. Now we will directly go to the hard tissue approaches, and we have two kind of hard tissue approaches. Mainly we are using, but a lot of hard tissue approaches are there. But we are using mobilization, and by mobilization, these four kinds of physiotherapy maneuver we are using. Especially, I have already showed Maitland sir's picture. So it's a Maitland approach is very common. And then Mulligan, and then Cartin Bone, and then McKenzie. So if we go for that is a Cartin Bone approaches, there is a grading is there. So I have mentioned that is Cartin Bone sir. He has given the range that is inner, middle, and outer range. So it is very important to during the we are using the Oxford muscle plate for muscle strength, and then also it's important to find out the active range and the passive range, and nowadays we are using the end field. So paraphysiological space, if there is something inside the joint, so find the final movement will not possible. That's why end field is very important during the CRX approaches. Here you can see some pictures that is Fritz law. Fritz law is very clearly defined by curtain mode approaches. Like on surface is convex, that is convex, and this is convex, and this is concave. So it's very important to know that when you can move which part in your on your treatment. Like if it is on acute stage, so you will not going to improve the joint strength in the acute phase, but you want to improve the minimal movement and the surrounding soft tissue circulation. So when you are trying to move your surrounding soft tissue, then joint will be moved. So, but what you have to do in case of acute movement, then you can move that concave surface. So nothing will change inside, no range of motion or space that is not alteredly changed. It will maintain. So your soft tissue will more increase circulation, but your joint structure will not change in case of acute phase. But when the chronic phase, there is a surrounding soft tissues are tight, then you can use your that is convex surface because it will create the space, it increase the usage space inside your joint. So that approach is also clearly defined by Curtin sir on his books. So in Maitland, there is an important thing is that is grade. So Maitland sir has given the 5 grade, and that 5 grade also is like a grade one is just joint play in the starting of that joint, and then the grade two is you can see the video here over here. So there is a first resistance is physiological block, then final stage is resistance two is anatomical block. So in between that, grade one is very limited and very short, and grade two is far more better, but is close to resistance one. But in case of grade three, it crosses the 50% more than that first physiological barrier, and also from the starting of that grade one. And then grade four is only the paraphysiological space is a fast physiological barrier, and then is just there over that there is a anatomical barrier, but in after just physiological first physiological barrier, then you can apply grade 4, and grade 5 is near to anatomical barrier. So if you can see another picture of this pressure, how many pressure you can give. So if you can see that's heading, so just see the video and you can find out some difference. Like this forms. So how many pressure you can give on grade 1 and grade 2 and grade 3 and or grade 4. So just see the videos and then you can clear. So if you give pressure, the response will go down. So, so grade, if it is grade 1, then pressure will be very few pressure. Then if it is grade 2, then you can see how many pressure will be, how much pressure for grade 2. So here you have to keep in mind that for acute pain management, if there is a severe pain, we are observing the pain by visually by VAS scale 0 to 10. So if the pain is more severe, then you have to use the Maitland gauges 1 and 2 only. Keep in mind that during the Maitland grade, if the pain is severe, then you have to use the grade 1 and 2. But if the patient can tolerate the grade 1 and 2, then you have to go to grade 3 because grade 3 can increase the range of motion. But when the range of motion is completely near normal, then you can go for grade 4. But after that you can continue that range is up to functional level, but you can during the end of the movement you can find some feelings like 5 kinds of feelings. It's a firm, spongy, or some like of feelings. So then you have to be keep in mind that that may be the cause of infill. So 5 kinds of infill are there. So then you have to give grade 5. So grade 5 we are applying by the techniques from Dr. James Sirex, is the husband of one of the physios. And then another approach is Mulligan. So Mulligan is a very nice approach, and there is two ways we can apply. Is like a hands patients is actively move, and therapist is here for guide the sustain the climb. So here patient therapist will not create any movement. Patient will just assist that accessory movement. So here I will ask somebody those who are on online. That is used to commonly ask the one question. There is how many types of movement we have. So commonly we can find that in our undergrads or in diploma or any other section. There's we have know that we have two type of movement that is called passive active. But I used to deny that because we have speed. Yes, we have two types of movement, but not passive and active. Basically, we have two movement, that is physiological and accessory. So you have to keep in mind that during mobilization or manipulation, we are mainly doing accessory movements. And physiological accessory movements, that two types has subsegment that is active and passive. So for 5 kinds of accessory movements, we have sliding, rotation, gliding, translation. So it's a distraction, traction inside. So those movements are inside the joint capsule and towards your body. This is called accessory movements, and those movements are away from your body. It's called physiological movements. So All kinds of mobilization we are especially used for accessory movements, but physiological movements also we can do. But McKinsey is another concept in physiotherapy, and here the basic difference is like that. Uh, the In case of Mulligan concept, we are only therapist will do nothing. Therapist will guide the movement. But in McKinsey concept, there what happens? There is the patient. Two types of movement can be possible. Patient can move, or therapist can help to move. So in Mulligan concept, also there is another concept is movement with mobilization. So there, patient move and therapist also gives a movement. But the basic difference is between that. In case of Mulligan concept, we are know that we place our hand just inside the affected segment. But in McKinsey concept, when we are guide the movement, then we are placing our hand above the affected segment. So some basics difference are there, but almost all are same. But the main difference is hands-on and hands-off. So in case of Mulligan concept, we have given a lot of home advice and patient self exercise can be possible. But in case of McKinsey concept, here patients hands-on and hands-off. Like we have given the exercise and put our hands on the patient, and patient are doing exercise, and patient can easily can do the exercise by their itself. So hands-on and hands-off is depends on the cultural barrier, because sometimes you are not treating directly the female or other sex patients. So that will be the cultural barrier. So then you have to think which technique you can apply, and that should be hands off will be suitable or hands on will be suitable. It depends on your patient's psychology and patient presentation to you. So please keep in mind. Another McKinsey concept is I have to go fast because already is then manipulation. Manipulation is a James Siriax concept, and it is you can see James Siriax approaches. And here we are proud to in from Bangladesh, that is we have Dr. Shantonu. Uh, he has the Asian teacher, and he used to give the lecture on Siriax concept. And this we are very proud Bangladeshis to have our senior pioneer in this field, and he is the first Asian Syriac concept teacher. And now Stephen DeConnick sir is he is continuing this concept around the world. So we can see his video. Okay, well, we have to go fast. And also we have cryopractice approaches, and cryopractice is adjustment of the bones. And here the approaches come especially by the treatment by the MBBS doctor who was expert of them, and also physios are there. But it's a very handy approaches, like you need support on your supporting tools like pain and special equipment also. So yeah, you can current by your hand, and also you can use your special weight for correct chiropractic. Another approach is like I already told you, that is a visceral approach. Is a unique physiotherapy term, and James Beardy Barrel is the founder of that approaches. And I think you can learn this approach by very great of pleasure. That is this is come from physios. So a lot of approaches in the world are come from physios. So you have to follow them, and you have to keep learning them and try to learn the specific things, and which is very correct and easiest way we can evidently we can practice, and clinical reasoning should be there, and which techniques why you are applying, there should be a clinical reasoning about that, and then you have to keep in mind, and that's the thing you have to keep in on your prescription, because you are applying visceral manual visceral so give me some another 10 to 15 minutes, because I need to show the all my slide, and that's all. So now Then we have to go to on rehabilitation approaches on the physio, because first of all, for muscle energy, muscle strength building, yeah, that is a proprioceptive neuromuscular facilitation techniques are stored by blueprint by during the birth and in the our chromosome, so from our father and mother. So this approach is very useful for fast doing any type of rested exercise, and also neuromuscular activation and progressive neuromuscular re-education and progressive rested range of motion exercise we are used to do. And there are final thing is core stability, very important. Core muscle, if you are going to strengthen that core muscle, then you can get the large time or big or long time benefit approaches. And then functional approaches, like sometimes patients are not good at function after the getting injury. So you have to be more functional oriented activity you have to practice with your patient. So then patient can easily rehabilitate on them. So another, I can show you the neuromuscular approaches, but it is not possible for now. So I think I have to in-depth it. So it's going to be concluded. And also, I have mentioned some that is facial reflex therapy. So you can just see the videos of facial reflex therapy. It's a non Sorensen approaches, and she's used to do these facial reflexes. So that approaches can help you to control that through the movement of the facial area, so you can find something that is more effective and give some movement here like this way. We have conducted a webinar with one of the lecturer from Jordan. He has already given this facial reflex therapy. So you can include on your prescription these approaches, and that can help you to manage the musculoskeletal pain, and also you can guide the patient to do that exercise on home base, so they can do by itself, and it is a totally safe method, so patient can do exercises, so do these facial approaches, and that can they can control their pain. So then I can go to associated approaches like your modification of shoe arches and insole, and your advice for as you as orthosis and prosthesis, and sometimes you correct the change the environment or modify their working place or living room areas. So this is very, or stairs or foot stairs or everything you will change for improve their lifestyle. So this is also your associated approaches, and then you can put that associated approach on your pillow on prescription on the left side or your RX. And the very beginning, from the very beginning, always we are talking with your patient. So it's a counseling. So without talking, our patient can't motivate it. So it's a fast approach is you have to explain everything, every approaches to your patient. It's a right for the patient. So when you are approaching your patient and you are trying to convince them, this is the counseling part. So it is always going on during before your treatment session, during your session, and in the other session. So it is very important. So you can write down on your prescription that is a patient education. Patient education means it's a counseling part. So now you can see that how you will put on your right side of your patient prescription. So finally, I can conclude that is your diagnosis you are making is professional diagnosis. Then if it is start your prescription, so what will abbreviate on the right side? You can maintain, you can put some main name of your electrotherapy like IRR, UST, or IFT or something. You can put the doses or time or duration out there. But during your first prescription, what you see, MFR, muscle and myofascial release techniques, or soft tissue approaches. You can use your neurodynamics. Next step will be neurodynamics for nerve release. Then you can use for, if you find any tight structure of the muscle, then you can directly go muscle energy techniques. And then you can apply position, that is positional release. If muscle is you have to release that tight structure, group of structure, then you can use a positional release. This is segmental. You can one by one you have to mention in the A and go for Z, not Z first and then A come last. You have to first MFR, then neurodynamics, then muscle energy techniques, then positional release, then you go for the postural correction. Then after postural correction, you go directly in the hard tissue approach, that is mobilization, and then you go for manipulation. Without mobilization, you can't go manipulation because it will create problem on this. It will damage your soft tissue. So after manipulation, you can directly go to proprioceptive neuromuscular facilitation technique for rested exercise. Then you can go neuromuscular activation, neuromuscular re-education, that is TheraBand you can use, or gym ball you can use plyometry, and then you can go to the core stability. This is very important because all energy can come from your core muscle, and then your limb are moving. So your energy, your pelvic and your thorax and all should be connected and re-educated the muscle, and affected part should be re-educated by the sound part. So all balance should be there, and then you can go for the proper rehabilitation of the functional activity. After core stability, you can directly go to the functional related which are affected due to this injury and due to this condition. So then after core stability, you can go for functional activity, and then you can, on functional activity, you can practice there anywhere. That is activity for daily living. That is what I said. The three segment of the ADL is that is self care, means from getting up from bed and going to bed. In between that time, what he is doing is called self care. Then called productivity, which is he's doing for earning. Like student, this learning is the productivity for him, because in future they can earn by learning or getting knowledge. And then self care is a leisure time, like which time they are for themselves in their own time. So this type of ADL activity you can practice after your rehabilitation program. So in conclude, you can give some counseling also. So already I have finished my lecture now today, but is in between some technical issue. Sorry for that. And one of this participant asked me, that is, I am already mentioned, that is, we are not treating condition, and we are treating only signs and symptoms. He is arguing about that, but this is very important for you. Just try to clarify it. That is, osteoarthritis. We can treat osteoarthritis. What we can do? We can change if damaged cartilage is there. We can invent cartilage, or we can regenerate cartilage. So what happened? We can maintain the muscle power. We can maintain the range of motion. That is called maintain. We can cure osteoarthritis. Osteoarthritis is the condition. Osteoarthritis is the disease process. So we are not treating the condition and disease process. We are only treating the sign symptom, like we reducing pain, we increase range of motion, we reducing inflammation, and we increasing muscle power, and we increasing activity. So some part of our treatment is we increase, some part of our treatment is we decrease, some part of our we improve, and some part of our we maintain. So this term should be keep in mind, that we are not create, we increase or decrease, or we improve, or we facilitate or improve, or we what is it? We improve or we maintain. So improve, maintain, and increase or decrease, but we not cure, because pain is our friend, not enemy. Okay, So it's a natural response to our brain, natural response to our body. So without that, we will not survive. Like that, we are maintained. So finally, I want to say that is we have a human body that is more than 70% water. So if anybody asks you why we give physiotherapy, because if you just assume that if you have 70 kg body weight, so how many how much portion of your body is fluid is, we said okay, more than 70%. So if your body weight is 70 kg, so 42 liters you have the water. So if you think that there is 5 liter only blood, so rest of the 37 liter is your fluid inside your body. So when patient are in bedridden like COVID patient, so how they will move that 37 liters? Then they need, whether the patient actively move, but bedridden patient can't move. So then the need of physiotherapy, because physiotherapy can passively move that part, 37 liter. So that's why physiotherapy needs. So it's not depend like we are naturally try to help the body. Okay, so we are not the person like fracture is not healing by medicine. It's naturally healed. So like that, physiotherapists are assist to heal that, but we are not healed that everything. So some part we are help, some part we are maintain, some part we are increase, some part we are decrease. So here in prescription, we can by A to Z, we have to maintain in an abbreviative word like MET, not maintain muscle energy techniques. Then what happened? This will be unique format for physios, and patient will know that this prescription is for only physios. They will not buy this on the medicine shop. This approach is only for physios, and they will go to another graduate or specialized physios. They will show that prescription to another professional, those who are on physiotherapy field. So that prescription should be unique. So thank you everybody. I think it's already a lot of time I have covered what is some technical issue. So you can visit it next time. If you want to visit our page again, you can see that video again, and we can modify that video, and we can present it in the short form. So you can easily watch again and you can find out. So any queries you can ask me now, or if any we have no queries, then we'll directly share our there is a feedback link. So by fill up that feedback link, you can access that. You have to go again your mail. You have to check that mail, and then you can find your e-certificate there. So don't be panic. Just fill your fill up feedback form now, and we'll share on our page or WhatsApp group everywhere. So you can just put your complete your feedback link and show the score, and then go to your email and check your feedback. There is a reply of that feedback link, and then you can get that your certificate will be on your email. So don't be panic. And another announcements for there, next Saturday we have one of my friend, Dr. Shumanjan Das, and he will come to deliver his speech on dry needle. So I will like to welcome you all for next webinar, and thank you all, and thank you for having patience, and sorry for the delay. Thank you. Thank you, Dr. Shamim. And now over to you.